Now we have another doyen in the field of pediatric cardiology, Dr. Singhi from Medica, but he is no longer restricted to Medica. He is in the Eastern India field, pediatric cardiologist. He will be speaking on uncommon finding in a common case. How not to miss.
Thank you, sir.
How many cases are you going to demonstrate?
Yes, sir.
How many cases are you going to demonstrate?
Only one, because to initiate and to give an idea, a single case will be more powerful.
Okay, thank you.
Yeah, I'll compensate for the time, and my day made by you, sir. Thank you. I must tell WBAE also to giving the opportunity. How not to miss in continuation of the our segmental analysis. One case, very, very unusual, and how we evaluated.
Timer, please. Timer, please.
So a 2-year-old girl weighing 7.6 kilo, she presented with cyanosis, clinically had 80 per minute pulse rate, first heart sound normal, second heart sound single, and there was a long systolic murmur in the second left intercostal space. So 84% with this finding, single S2 and long murmur, so clinically was possibly a tetralogy physiology. Chest X-ray, cardiothoracic ratio around 0.5. Overall, periphery was having less blood flow. I'm showing some image from the subcostal. We can appreciate the subcostal view showing large VHD. If I can get a... So the large VHD is seen mainly by the right to left shunt. We can appreciate in transiently the outflow obstruction also. The outflow obstruction is very nicely visualized in the right ventricular outflow tract in short axis. You can appreciate the gradient there. It was a severe infundibular and annular pulmonary. Thank you, sir. So it was a severe infundibular and annular stenosis we can appreciate. We'll continue to see in all other views. In congenital, we see something, we cross-verify in all other views, then only we are more comfortable that yes, we are seeing something which is more pathologic. So we are seeing a gradient which is more than 100. 116 may not be actual one, maybe overestimation. So it's a severe pulmonary stenosis. VHD PS up to that is okay. Yeah. One odd finding here, we always discuss that tetralogy should have a right ventricular hypertrophy. We are seeing also a thickened ventricle, which is left ventricle. There are few causes, we'll come to that. We are seeing biventricular hypertrophy, which is not a common thing for a tetralogy of fellow. We expect a right ventricular hypertrophy. In the apical four-chamber view with little superior sweep, we can appreciate this is that aortic override, subaortic VHD, and on the pulmonary stenosis also in some sweep we are appreciating. This is that VHD I have marked it. So parasternal long axis view, aortic override, significant, and bidirectionality of the flow. This is the VHD I have marked. Parasternal short axis in view showing the RVOT. This is the turbulence, anterior deviation of the conal septum, significant turbulence, and smallish branch PAs. We can appreciate the branch pulmonary arteries also here. So the branch pulmonary arteries are well open in the next parasternal short axis sweep. RPA flow we are seeing, LPA just origin we are seeing. So far we have seen a large subaortic VHD, severe infundibular annular pulmonary stenosis, and confluent branch pulmonary arteries. Again, short axis, this was little odd, seeing an LVH in addition. So it is a biventricular hypertrophy. So initial impression though is a large ventricular, conoventricular defect with bidirectional shunt and outflow obstruction of the RV. The arch started showing something. The arch turbulence, we could not see arch very well. This is that some turbulence in the arch, we could not evaluate arch well. we could not explain. So possibility of arch obstruction we were thinking, and that biventricular hypertrophy was also in mind. We went back to the basic. Again, segmental analysis, we saw that this pulse wave Doppler analysis of the descending thoracic aorta, it was not nicely pulsatile. Dr. Ishita was showing a very nice, well pulsatile Doppler of the descending thoracic aorta, which was not there. So it was more blunted. It was not a pulsatile flow. Dedicatedly trying to see the aortic Doppler, we could appreciate there is an obstruction which is high up in the middle of the thoracic aorta, so we could not see very well from the arch, and it was showing significant gradient. You can appreciate the max gradient was 65 of the arch. So it is coming towards the probe, so it is giving an positive deflection. We did a CT angiogram and it showed a long segment coarctation of aorta. So we were dealing basically with a tetralogy of fellow with long segment coarctation of aorta. This is showing RVOT and branch pulmonary arteries were good. This is the obstruction in the RVOT. So 3D reconstruction nicely documented a long segment narrowing of the arch, descending thoracic aorta. It was a right arch with long segment hypoplasia of the thoracic aorta. So we planned for stenting of the long segment followed by intracardiac repair, but as we were discussing COVID, how Devdatta has shown, during that period, COVID, parents communicated that multiple people got affected, multiple deaths in the family, so they wanted to defer the surgery and they lost to follow up. That's the odd part. So we lost to follow up, but I thought it is wise to share a rare anomaly that two obstruction of both outflow is against the philosophy of Rudolph's flow theory. We only usually get one-sided obstruction. It's extremely rare, and 0.04 patients of tetralogy may have obstruction to the left side. So it is 4 per 10,000 patients. So it's so rare. Even in that rarity, it is usually left-sided arch if it is, then distal to the left subclavian artery, discrete or interruption. This type of long segment obstruction of the descending thoracic aorta is not reported so far. Diffuse hypoplasia, as we are discussing, is rare, and it is very important to have a detailed evaluation, suspicion, so that we can plan the therapy very well. So initial clinical evaluation, when we were seeing the pulse wave Doppler of the subcostal image of the aorta is extremely important, not to miss that component. And when we are suspecting in these cases, computerized tomographic angiography always helps to delineate the anatomy and plan the intervention, and we wrote, and this is accepted for publication. So thank you, sir.
Thank you. Is it the only case you are going to do?
Yes, I have shown only one case.
But
because I felt it's
absolutely wonderful, absolutely wonderful. Another 1 minute. Yeah, and I think two things are important. One is anything striking should strike the mind, as in your case, the LVH, that why it is there in a fellow.
Yes, sir. Yes, sir.
That is one. Another is the routine interrogation of all the structures.
It's so important,
So
sir.
finding one thing should not suffice. For example, finding a VSD isolated is not the everything. You have to search for other things. Seeing a bicuspid valve is not the everything. You have to search for other things, a PDA, a coact, etc. So something are associations, routine associations, like I said, but this is an unusual association. That also be, so this is open for discussion. And I congratulate you that it is already accepted for publication.
Thank you, sir. Thank you.
One important question regarding the management of this case. What do you think intracardiac repair with along with the stenting of the coact of the aorta?
Yes,
But
hybrid.
which should be the first? Whether
Yes, a very nice question. There was a meeting and the discussion was we'll do the stenting of the arch. We'll relieve that component, and surgeons were happy to take from my cath lab to the theater. That was the plan. Yeah. We got the stent also, and stent was ready. But It was
Because
COVID.
that is the actually that should be, because otherwise if you do the intercardiac repair later
No,
on,
no,
this
no,
will
no,
be-
no, no, they have-
or
they
you
wanted
can
us
do
to take care.
simultaneously the cath lab. if
Yes,
it
yes,
is
correct. You have absolutely correctly told, sir, that left obstruction to be relieved first.
This decision of stenting followed by surgery, was
Yes,
it
sir.
your own decision or was it a team decision?
Team decision, sir. Because I cannot take this patient without my surgeon with my side. Impossible, sir.
Okay, but did they think that this could be repaired by them? The whole
No,
thing
it was
could be-
very long segment. They don't want to go that arch because they wanted, if it is, they are more happy with the lateral thoracotomy. From the front, they cannot. So they wanted me to sort out this and then they will take.
Okay.
And
Yes,
another
Dr.
thing, we
Jha.
have nice stents nowadays, like formula stent, which can be post dilated up to 20 millimeter. So if we are putting a stent in a 2 year, there is no problem. We can post dilate to adult age up to 20 millimeter. So it will not cause a narrow arch aorta in the future long run. Yeah.
Only thing a coarctation is that sometimes we have to also search for the regarding the aneurysm in the and the cerebral circulation.
Yeah.
That should be
I
screened
think
for
very
it.
nicely, berry aneurysm. So definitely.
that because it's such
Yes,
a-
yes.
No, Dr. Jha, is it in your mind that you could deal with the aneurysm as well or just a finding?
Whenever we are dealing with the coarctation and association such a complicated of that,
association is
I'm
there,
thinking
but
of that.
This we came to know part 2.
Yeah.
If we know, suspect that this is definite coag, at that time that same angio can screen the head also. We need to be telling the radiologist beforehand. So that in single sitting, single contrast work can be done.
That was very interesting case.
Thank you for a very interesting case demonstration. Give him a big hand at least, if you have not asked any
Thank you, sir.
question. So, this is not the end. We have another giant of pediatric cardiology field. All of them are good, doing good interventional cardiology also, though today they are restricting themselves to imaging. But they are doing very good job in Calcutta in interventional cardiology also.